Welcome to the show where we share the stories of the many who intersect with our healthcare system but are rarely heard from. Subscribe at kevinmd.com/podcast. Today, we have a special sponsored episode from Sanofi. Our guest is Dr. Jennifer Goldman. She's a professor of pharmacy at the Massachusetts College of Pharmacy and Health Sciences, board certified in advanced diabetes management, and a certified diabetes care and education specialist. Today, we're talking about applying the 2024 ADA standards of care into practice, a practical approach to basal insulin in type 2 diabetes. Jennifer, welcome to the show.
Thank you so much. Thanks for having me. I appreciate it.
Yeah, so let's start by briefly sharing your story.
Sure. So I've been practicing actually for 34 years. And about the last 27, I've been really hyper focusing in diabetes management and cardiovascular disease and so forth. So I, like you said, I do teach at Mass College of Pharmacy. I teach in the pharmacy program and the physician assistant program. And I spent 15 years or so in family medicine with Tufts University Family Medicine Residency Program. And the last 12 years, I've been in a private practice in internal medicine with one doc, me, and 3 nurse practitioners. And when I established there, what I did was develop and direct now the cardiometabolic services at that practice. So that's where I take PharmD students and fellows and residents on rotation to really just train them in clinical management of patient care.
All right. The 2024 Standards of Care, published by the American Diabetes Association, incorporate new guidelines for managing comorbidities and emphasize the importance of self-management and education in diabetes care. So, Jennifer, what are your takeaways from the ADA guidelines in terms of intensifying injectable therapies?
So the standards of care, they really encompass all of clinical practice recommendations. They are updated annually, but they are updated in real time. So that's important to remember. So when any impactful trials, impactful outcome data comes in, it's going to be updated in real time. It's available online, updated, but it's also available in a free app. And I think that, in terms of intensification that you just asked me about, it's important to understand where the standards are. And so they do actually recommend rather than insulin. So, traditionally for years, basal insulin was the go-to for intensification. And now the recommendations are to use incretin therapy. So a GLP-1 receptor agonist or a GLP-1 GIP receptor agonist as the first injectable over basal insulin whenever possible. And the reason we do that is to minimize hypoglycemia. And like you said, incorporating weight loss, which is also an issue with people with type 2 diabetes. So in addition to doing that, the recommendation is to not wait. Don't keep putting it off. Okay, go lose a few more pounds or come back in 3 months. It's really that intensification now is what the recommendation is.
What is the current role of basal insulin in type 2 diabetes management?
So basal insulin with once a day, it's really to reduce that hyperglycemia. So helping with that overnight, the in-between meals, fasting, background insulin. So replacing that missing background insulin.
And what are the different types of basal insulin?
So we have long-acting basal insulin, and that includes U100 glargine and U100 detamere. Detamere is not going to be produced anymore, so all we'll have is U100 glargine. And so those are the long-acting. But then there's longer-acting basal insulin, and the longer-acting basal insulin includes U300 glargine and U200 degludec. And so in the standards of care, the long-acting basal insulin, U100 glargine and detamere, decreases the risk of nocturnal hypoglycemia compared to NPH. But the longer-acting basal insulins may convey a less hypoglycemia.
And in patients with type 2 diabetes, who is a good candidate for basal insulin?
So most patients with type 2 diabetes do require combination therapy. So they're not necessarily going to be able to take one pill or one injectable and move on. Most people are going to require a combination. So when do we want to use basal insulin is if somebody has severe hyperglycemia or somebody is glucose toxic and symptomatic, we want to make sure that we have that available. And so we can add that on. So we're going to potentially decrease those symptoms and help people actually feel better, get out of that toxicity.
What would constitute severe hyperglycemia or glucose toxicity?
So in the standards of care, they do recommend basal insulin for anybody. This should be considered for anyone with an A1C greater than 10% or levels over 300. But what does it look like if somebody is glucose toxic? This might be somebody who comes in and they have catabolic features. So that could be weight loss or ketosis, hypertriglyceridemia, or someone who's really symptomatic. So polyuria, polydipsia, severe fatigue is also extremely common when you have somebody glucose toxic.
So, Jennifer, take me into your exam room and tell me what that conversation looks like with a patient who needs to start basal insulin therapy.
So, Kevin, one of the things I do when I first meet patients, even if they don't need insulin. So even if they're sitting in front of me, they don't have insulin, I'm always having a conversation with them about the pathophysiology of diabetes, what is happening in their body and what might happen. So not everyone's going to progress and need basal insulin, but a lot of people do. So I have that conversation early. So I have that explanation. We don't need insulin today. I talk about what insulin is and natural insulin, and that at some point they might need it. So I want to make sure I keep that message very positive. And if we have to cross that bridge, we will cross that bridge when we get there. And, that reminds me of a patient a few years back. I had a patient referred to me. He had been started on metformin, 500 milligrams twice a day, and his A1C was actually about 10.5. And so when I met him and had a conversation with him, he had weight loss, which, in his mind, he's thinking, this is great. I lost this weight. And I said, but was it on purpose? And it wasn't on purpose. So he had weight loss. He had extreme fatigue and extreme thirst. So that is a really good example of a patient with glucose toxicity. So he presented as an early diagnosis. So the conversation with him is different than somebody who's maybe had diabetes for 15, 20 years. So this patient presented early, and this was, right at diagnosis. And so the conversation with him was the importance of early insulin use. So to get him feeling better, get him out of this toxicity. So I started him on a longer acting basal insulin, gave him a titration schedule. Once he was feeling better, his A1C was better, everything was really better for him. I was able to add a GLP-1 receptor agonist to his regimen and back off on that insulin. And then I used CGM and added an SGLT2 inhibitor and was able to actually take away the insulin completely. So early insulin use may lead to almost a remission of that toxicity and allow you to use other drugs. And he's doing great today. His A1C is less than 6.
How do you choose the appropriate basal insulin for your patients? And what are the key differences between basal insulin analogs? And how do these differences impact their use in type 2 diabetes management?
So remember what I mentioned earlier was hypoglycemia. And so we have less hypoglycemia with the longer acting basal insulins. Despite that, just so I don't forget to say this, if we use any insulin in anyone, I always make sure that we talk about hypoglycemia and everyone is empowered with having glucagon available to them. But so how I'm going to choose is I sort of start at the top because we know that we have longer half-lives with the longer acting basal insulins that truly reach, 24 hours. But when you look at the standards of care in terms of recommendations, the most important thing is helping a patient, empowering a patient. You don't want to start them on 10 units. So standards of care say use 10 units or 0.1 to 0.2 units per kilogram. Either one is a good starting place, but you have to empower the patient to self-titrate. So, for example, with this patient and with most patients, that might look like 10 units, and then have them check their fasting blood sugars, whether it's with finger stick or with CGM, and increase their insulin by 2 units every 3 days to a target. Most people, that target's going to be 80 to 130 to target less than 7%. Because remember, we want to bring them back. We want to make sure they're not having hypoglycemia, but we don't want to give them 10 units and say, I'll see you in 3 months. We want them to be titrating on their own so that they're moving it along. We want to intensify. We want to make sure they get to their target.
Once you've selected the right basal insulin for your patient, how do you start basal insulin in a patient with type 2 diabetes who is new to basal insulin therapy?
So like I said, with that patient, you start low, go slow. Sort of what I say with metformin. Start low, go slow. Because if somebody's toxic, somebody has hyperglycemia and their blood sugars are in the 300s, we don't want to bring them down to 120 overnight. They didn't get there overnight. And if we bring them down overnight, they're not going to feel well. So start low, go slow, 0.1 to 0.2 units per kilogram or 10 units, and titrate them. Empower them to titrate themselves, and then make sure there's touch points. And it's important to not just leave them alone. The other thing that's important is, and this is recognized in the standards of care, Kevin, that if you use combination therapy with a GLP-1 receptor agonist or a GLP-GIP, you will have more sustained blood sugar lowering with that basal insulin.
What are the typical challenges you see with basal insulin?
What's interesting, Kevin, is that when you think about barriers and you have that conversation, it's often thought about that it's patients, but providers actually have barriers to insulin use. And so there's lots of different things. Time constraints certainly make a difference, but I think understanding that it's available, basal insulins are available in a pen device now. And interestingly, providers actually have a fear of needles, and as well as patients. And so understanding that needles are thinner, they're smaller, they're small as an eyelash, and kind of getting rid of that. But also for providers, not wanting to alienate their patients, not wanting to, I'm going to give you insulin. And especially what's important is never using insulin as a threat, and truly understanding that some people are going to use insulin, and it can be done easily and simply. But I can understand how providers would be afraid potentially of hypoglycemia, just like patients. So barriers to patients, similarly, is fear of weight gain and hypoglycemia and pen needles. So now you have both sides. Okay, doc, can you give me another 3 months? I'll lose the weight. Or why don't you take 3 more months and lose the weight? You can always take insulin away, but this is what you have right now. So it's important to have a positive message, and that's why I talk to them early. So when I say, early on, I have a conversation about basal insulin so that we can sort of get rid of those barriers as much as we can. And it has to be a positive message. It truly needs to be a positive message.
And my final question, Jennifer, what are some of your take-home messages that you want to leave with the Kevin MD audience?
So I think what's important to understand is that the longer-acting basal insulins are preferred by the ADA standards of care because of that lower risk of hypoglycemia. So it's covered by most insurances. So I try to use one or the other first because they do have that longer half-life. They do last that full 24 hours. Basal insulin helps regulate people's blood sugars, helps them with their fasting, and can improve microvascular complications. That's very well known and well established. Most patients are going to use basal insulin as a complement to the current therapy. Everyone feels better when they're on basal insulin if they're deficient of insulin. When you use basal insulin early, so if someone's glucose toxic, use it early. That can help preserve pancreatic function so that you can even possibly get them off insulin and use other therapies. And we should really consider it for anyone with markedly elevated blood sugars. So incorporating it. So as you said right at the beginning when we started talking, is that the standards of care recommend this personal approach for each patient. So look at everyone as an individual, thinking about the long-term complications, and finally, I would say with the proper education, the proper support and monitoring from providers and healthcare professionals, basal insulin can be used safely. It can be used effectively. It's an excellent treatment option. It works for everyone. It will always work. And have these conversations early with a positive message for your patients.
Connect with us in the coming weeks on LinkedIn and X. I'll leave the links for both of those in the show notes for the next part of this series, where you could learn more about the different types of basal insulin analogs to manage type 2 diabetes. Jennifer, once again, thank you so much for coming on the show and sharing your perspective and insight.
It was a pleasure. Thank you so much for having me.